Good evening, everybody, and welcome again. It's Friday. The whole week seems to be Fridays. It's always Friday. Welcome, welcome this evening. Uh, we are here again to try and please the NGO called She Chooses to Live Initiative, which has given us the mandate to talk things health-wise, to talk things about health, and to let people know if they would be helped by what we tell them. So we are a organization that likes to really just expose things as they are. We are wanting that people should choose to live, should choose knowledge, and once we have knowledge, we can make the right choices, and then maybe that would help in life in future and even in the current circumstances, even with this COVID. So we need to know quite a lot. So we come here on the platform called Against She Chooses to Live Initiative, and we talk about things health, mainly things reproductive health, but we talk many other things, concerning health. We uh, I have here my tech guy or tech girl. I don't know what she is, but she's a tech girl. She's the one who puts me on and makes sure that I'm on Facebook Live. And then at the end, she removes me and looks for questions that we need to answer. So that's my tech guy here. Very, very efficient tech guy, I must say. I'm Dr. Jen Wakahe. I'm gynecologist by profession, obstetrician gynecologist by profession. I've also done public health, and my biggest passion is to let the people know. I've noticed how much lack of knowledge there is in my people, in our people here. I try to compare them with other people from other countries because I look after all kinds of people, and those people from especially the Western world are very very informed about especially their bodies. In our country here, it's like it's a taboo to know anything about our body, especially the female body. And it is time we expose because every part of our body is a part of our body, beautifully and wonderfully created and for a reason. So we need to know how it functions. We need to know what it looks like. We need to know when there's a problem with it. And we need to call, if it's a vagina, we call it a vagina and say it does this. Uh, I'm not saying that we go saying on the streets vagina, but in forums like this, we can't be saying susu, kasusu. I don't know if it's kasusu or kahot. You know, if it's a penis, it's a penis. If it's a vagina, it's a vagina. And it is worth talking about and knowing exactly how we are formed, exactly what can go wrong. And I encourage people to actually know themselves, to know what they look like everywhere, so that if something changes for the worse, then they know, or even something changes for the better, they also know. So it's good to know yourself, woman, know thyself really, from head to toe, and then we can combat disease long before it sets. When disease, any kind of disease, if it is caught early, most times it is possible to deal with it. The issue is when it has stayed too long, and then it's whoops, we can't manage it. So this is a forum that wants to lay bare, not in a bad way, but to lay bare especially the female body and the male body sexually, uh, so that people know and people don't shy away from asking questions. We like some of us were brought up when nobody would talk about even periods. They caught you unawares. You didn't know what was going on, or if it was said, it was whispered. So this is a forum to talk and say that sex happens, that things do happen indeed, and that we need to know. And although we will leave them in the right place, but we need to know what goes on. So that's what She Chooses to Live initiative is trying to do. And here we are again tonight. We talk about topics that people ask over and over again. And we request that if you want a topic covered here, just post it to us. We shall try and get the time to talk about it. So today we are talking about something called endometriosis. A lot of people have asked about endometriosis. So that's what we are going to discuss this evening. It's not a very long topic, so we hope to finish it not in a very long time. Water again as usual. So let's talk endometriosis and what it's all about. So if we started by what is endometriosis, in the inside of the womb where the baby lives, there is a layer there called endometrium. It's made of what is called endometrial cells. And this is the layer that makes a sponge every month, waiting for an egg to be fertilized and come and land on that sponge and start making a baby. And when the baby is not made, when fertilization doesn't happen, then this is the same sponge that breaks and comes out as periods. The one I told you people that is called the weeping of a disappointed uterus, because it's weeping because it didn't receive its gift of a baby. So this is what is the endometrium. Now, when these endometrial cells migrate and are found outside of the uterine cavity, they're supposed to be only in the uterine cavity awaiting to make a sponge for the baby. When it is that they are found outside the uterine cavity, then that is called endometriosis. And that's what we are going to talk about this evening. Now, how frequent is endometriosis? And statistics show that up to 10% of all women during their reproductive age, 10% will get endometriosis, which makes it quite a common problem, because endometriosis is quite a problem. Now, what causes endometriosis? The actual cause of endometriosis is not known at all. Nobody knows what the cause is. But having said that, there are some situations that may cause somebody to get endometriosis. And the biggest of them all is that it could be genetically engineered, in the sense that you wanted to find endometriosis running in families. If there was a cousin or an auntie or your mother or somebody with endometriosis, then you have a chance of also getting endometriosis. So it is maybe a genetic predisposition. I say maybe because nobody knows 100%, and nobody knows exactly what the cause is. The other cause that is said to be the reason for endometriosis is that when a woman is having a period, and it's supposed to come flowing from inside the uterus down through the cervix and out into the vagina and out into the air, into the pad, then in some cases, the bleeding, the blood that is being bled, the endometrial cells, will flow backwards. Will flow what is called retrograde. They'll flow backwards and flow into the tubes of fallopian tubes, and finally flow into the abdominal cavity. Now going and landing there in the abdominal cavity through the tubes, and that is causing endometriosis. Then there is also a theory, thinking that in some people, the cells at puberty have something that they change about, and those cells that are outside the uterus and are in the abdominal cavity, like where the omentum is, then they tend to change into endometrial cells during puberty, during when the hormones are changing to make a girl into a woman. Then there is a thought that sometimes maybe the endometrial cells are carried by blood or by lymph to outside of the uterus. And this would actually explain why sometimes we find even endometriosis in the lungs. We find it as far as away as in the lungs, which means that something carried it. there, which is usually either blood or lymph that carried it. That's another way of thinking how it comes to be. Then there is a fairly common way, and that is surgical transfer. Sometimes when we are doing a cesarean section, as we do cesarean section or in the surgical procedure of the uterus, in the opening of the uterus, we usually will get right inside into the endometrial cavity where the baby lives. That's we have to get there if we are removing a baby. And sometimes that accidentally, that those cells can be transported outside surgically by accidentally, not that it is intentionally, and those can start to grow outside of the uterine cavity, and then they make endometriosis. And then finally, the other way is that some people have an immune problem, so that they are not able to convert cells into, like, change the endometrial cells that are outside the body and destroy them. Their immune system is such that it allows those cells to grow. So those are the so-called thoughts about what causes endometrial cancer. I mean endometriosis. The one thing we know for sure is that it runs in families, and as to why, which family, and as to how it started off, it's not very clear to anybody. But yes, it's a very common problem. Like I said, 10% of women will get endometriosis. Now, which woman is at risk? I already said it's somebody whose family members have endometriosis. That woman is at risk. The other woman who is at risk of getting endometriosis is a woman who has never given birth, what is called an oviparous woman. If you've never been pregnant, you've never given birth, you are at more risk than everybody else of getting endometriosis. The other people are people who start their menarche very early. Menarche means that onset of periods. So that there are girls who are starting periods even at age 9. We have a mother in Kenya who is 9 years old. So there are people starting their periods very early. And those who start pretty early have a higher chance of getting endometriosis than people who start at the normal time of 12, 13, 14 years. Then there is those women who will go on with periods until the menopause comes very late. So women who are going beyond 55 years, and they are still getting their periods regularly. I know a few who reach 60 and they are still getting periods. Those are people who are at risk of getting endometriosis. The other people are people with a short cycle, from start of period to start of period. Those people with the cycles of those 21 days, 22 days, those women are more at risk than the women who are 28 and 30 days cycles. So shorter cycles cause a bit more risk. Then the people who have very heavy periods, and this can be explained in the sense that if it's so heavy and it's not being able to flow out downwards, then it's likely to flow backwards and flow into the tubes and form endometriosis through the tubes. So heavy periods is one of the reasons. This one is going to be a very is this one the next point is a very interesting one, because it's the first time you'll hear that being thin is a problem. So that if you have a very low BMI, uh, you start you start getting you start getting you stand a bigger chance of getting endometriosis than those of us who are gifted with a bit of fat cells. So low BMI for this time is not a very good thing where endometriosis is concerned. And then people who have very high estrogen levels, people who are also on estrogen replacement, like people who are taking hormone replacement therapy, whatever elevates the hormone called estrogen, then puts somebody at risk of getting endometriosis. So those are the people you look at, a very thin person and you think endometriosis. Anyway, that's just a by the way. Now, what organs does endometriosis hit? What organs does it attack? And we said that endometrium is supposed to be only inside the uterus, where the baby lives. It's supposed to be getting ready to make the placenta for the baby. So when it goes outside, the main organs it hits, the first commonest organ it hits is the fallopian tube. Uh, that that would be necessitated by the fact that if it is a backward flow, it is a flow through the fallopian tube, and then the endometrial cells will attach to the fallopian tube itself. Then the other one is the ovary, again by proximity of it to the fallopian tube, because the ovary is at the mouth end of the fallopian tube. So if there are endometrial cells flowing through the fallopian tube, then they are likely to land on the ovary. Then the the fallopian tube would pour the blood into the pelvic cavity. So the whole of the pelvic cavity is at risk of getting endometriosis. The next one is the bladder. The bladder is part of what shares the pelvis, that the bladder can be attacked by endometriosis. Then the intestines themselves. Then there is the thing called momentum. Momentum is like a nice shuka that covers intestines inside there, and it has a lot of good use, but it can be attacked by endometriosis and become quite a problem. And occasionally, of course, there is the time that you'll find it not very common, but it will happen that it goes to places like the lungs, distant places. Now, if these organs are attacked by endometriosis, what happens to them? The issue is that these endometrial cells behave exactly like the endometrial cells which are inside the uterus. So they follow the hormonal cycle, the hormonal menstrual cycle. So just as the endometrium thickens to make a sponge to eat for a baby, when these hormones are released, then the endometrial cells that are outside the body also thicken, awaiting to make a sponge, awaiting also a baby. I don't know where they are awaiting a baby from, but they thicken. When it is time to have menstrual flow from the uterus, then these cells also are also breaking down and having menstruation. They are bleeding outside there, on the bladder, in the fallopian tube, on the ovary, in the pelvis floor. They are bleeding there. Now, unfortunately, unlike in the uterus where the blood has an outlet and it can flow out, here there is no outlet for the blood. So what happens is that it keeps bleeding and keeps thickening and keeps bleeding and keeps thickening and mats organs together in the pelvis, and wherever else the bleeding is happening, mats organs together, and this keeps getting bigger and getting worse every menstrual cycle that somebody gets, because every time you menstruate through the uterus, you're also menstruating outside on the bladder, you're menstruating on the intestines, you're menstruating this everywhere. And when blood happens like that, where it is not in a blood vessel, if blood pours on those organs, then what happens is that those organs get very irritated. You can imagine matting with blood that is going nowhere, that is breaking down and going nowhere. So there is quite a bit of irritation on those organs, and sometimes quite a bit of what is called inflammation. Then there is also scar formation. It can make a scar on those organs, because it's blood that is there that is going nowhere. And once it has been bled out, now it's not living. So it will rot, it will die, and it will mat on the organ that is supposed to be there. I mean, where it is sitting on. And then with that comes what is called adhesions, that things, organs get stuck together in the pelvis so that things do not move easily. In the abdomen, everything is free to move. The intestines move, even the uterus goes back and forth, even the tubes move. But when the adhesions happen, then even the intestines cannot move freely, and things have adhesions. So, having explained all that, what are the symptoms? What then, when this happens, what symptoms does somebody get so that they start to suspect that they have endometriosis? And the biggest problem is painful periods. And I say pain and pain and pain. Painful periods, both inside the uterus itself, but because they are bleeding outside the uterus. So there is pain as the periods are on. The whole of the pelvis is in pain, indeed, a lot of pain. The other one is that there is that other thing we discussed the other day called dyspareunia. Because of these markings of blood and adhesions that hold organs together, then when having sex, it can be very, very painful indeed. So dyspareunia or painful sex is one of the other symptoms that people get. Then there is, again, I'll keep saying the word pain because endometriosis is painful. So there is pain around the pelvic region that is very it comes more with the periods. It is worse during the periods, but it doesn't ease with periods because the blood went nowhere. So there is pain everywhere. Then there is pain as one passes stool. As one opens bowels, there is pain because then the intestines are not freely uh, doing their peristalsis and moving things as they should. So there is pain during passing stool. There is pain during passing urine because again the bladder has been matted around. There can be diarrhea. There is definitely bloating, and there is nausea, and there is constipation. Those are to do with the fact again that the intestines are not being able to move very, very well. One can have quite a bit of back pain, and that's because there is a place there between the rectum and the uterus called the pouch of Douglas. And if there is blood that is poured there, which sometimes it goes there because the fallopian tubes can pour blood into there, then it can be very painful. The back can be absolutely painful. And then finally, because of bleeding uh, so many places, including the uterus and outside the uterus, then people will have quite a number of people with endometriosis will have anemia and will kind of be always fatigued because then they are losing a lot of blood. But the good thing is sometimes there are no symptoms. If it is, there can be endometriosis very early indeed, and there are no symptoms. But when it is set in, there are those symptoms. And again, I repeat pain, because pain is the biggest thing about endometriosis. Now, how is endometriosis diagnosed? We've heard all those stories about what will make you think you have endometriosis. How is it diagnosed? And one of the things is by very, very detailed medical history. We sit and we talk. When does the pain come? Because usually what brings somebody is the pain. Sometimes it's infertility, but most of the time it's the pain. So when does the pain come? How long does it last? Many things. So a good history of when the pain happens. Then the other one is to examine the pelvis, what we do, what we call by manual, examining the pelvis with both hands. And sometimes we can be able to detect areas that are swollen with those endometrial cysts, and they are painful. So sometimes just physical examination in the pelvis, we can be able to start suspecting that there is endometriosis in somebody. Then usually we will set somebody for a pelvic ultrasound, and this will show areas of uh, solid areas where blood was and blood matted, and yeah, they'll show what is called endometriosis. And usually the ultrasound will say there are such things as endometriosis indeed. Uh, then there is we can even do an MRI, which is a more detailed radiological examination of the pelvis, and this will also even help us to see how even the things the organs are arranged together. But another the actual, if we have all this and we have all these suspicions, we can also do what is called laparoscopy. Laparoscopy, I think many of us, Princess Diana, know what it is, but it's what is called minimal access surgery, so that somebody puts a probe into the abdomen and actually looks with their own eyes. And there you see chocolate things in the abdomen, around the bladder, in the intestines, around the fallopian tubes. So laparoscopy is actually definitive diagnosis. You will be able to see with your actual naked eyes. Now, laparoscopy is used not only to diagnose, but although I don't treatment, sometimes I don't talk treatment here, but laparoscopy can be used to also reduce some of those endometrial swellings, because the bigger they are, the more they will bleed and the more it will pain. So if we could just shrink those swellings, then it would help. So during laparoscopy, sometimes when we find that it is endometriosis, sometimes we are able to also reduce, cut it off or burn it off, and reduce the amount. Now, what are the complications of endometriosis? Uh, there are two types of complications. There is the physical complications of endometriosis, and there is the psychological complications of endometriosis. Now, for the physical ones, again, we start with the word pain, because pain, you cannot escape pain when you have endometriosis. So it is severe pain in the pelvis, in the abdomen, quite a lot of pain. And wherever else the endometriosis would have landed, each time it gets to be very, very painful. Then the other problem is things called adhesions. Those ones where things match together, so that if somebody were to need surgery, then it becomes a big problem to maneuver through those, how the organs have matted together, and the adhesions also stop the organs free movement, so that things like constipation again will appear. The commonest, the most, shall I say, feared complication of endometriosis is infertility. And this comes about because when the bleeding happens into the fallopian tubes, then the fallopian tubes will be blocked by this blood. Fallopian tubes can get blocked by infection, but this one will now be blood flowing through it, matting in there and blocking the fallopian tubes. And not only that, the tubes can actually be partially open, but the presence of endometriosis tends to destabilize sperm and to also destabilize the egg. So it becomes even harder for fertilization to happen, even if it was going to be possible to go through the tube. So before the tube finally completely closes because of endometriosis, then even the sperm and the egg may not be allowed to pass through and get to each other and get to fertilize each other. So infertility is one of the biggest problems that we have to deal with when there is endometriosis. The other one is that when somebody has endometriosis and if they happen to have what is called an endometrioma, that means endometriosis into the ovary, then they stand a bigger chance of getting ovarian cancer than the person who didn't have an endometrioma, who didn't have endometriosis in the ovary. Then there is a certain cancer of the uterus called adenocarcinoma of the endometrium, and that one is more common in women who have had endometriosis more than the other women. So those are the kind of complications that we are talking about where endometriosis is concerned. Now, what are the psychological issues? This is due to the fact that endometriosis, again, I repeat the word pain. I don't know how many times I will say the word painful. Endometriosis is painful, and it is what is called a chronic disease. It's not a pain that comes and disappears. It's a pain that is always there, and you're waiting for it to make another peak the next time and another peak the next time. It's always there, but it peaks, but never goes away. And because of this chronic nature and the pain, then a lot of women with endometriosis will actually get depression. They'll need treatment for depression. Some will get quite a bit of anxiety. And much of the time, there is need to coordinate both psychological treatment and physical treatment. Now, what is the management of endometriosis? Again, I always say here, I do not manage on this platform. I just let you people know so that you can go to your doctor and get checked whether you have endometriosis or not. But let me say this, that the earlier endometriosis is discovered, the more likely it is to manage. Now, there is no cure for endometriosis. There is none. What there is management of the symptoms. So we can manage the symptoms, but we are not able to cure. Fortunately, if there are very nice cures around. If you get pregnant, then it eases, because for the 10 months that you're pregnant, the endometrial cells are dormant. They are not trying to make a sponge to receive a baby. So it eases with pregnancy. It will usually ease once a woman reaches menopause, unless the woman is taking estrogen therapy, in which case they can even start getting endometriosis after menopause. So it will ease with menopause. Now, I think the biggest takeaway here I would want to say is that because endometriosis interferes with fertility, if you are to discover that you have endometriosis and you are to want to have fertility, then please do not delay fertility. If you are to want to have children, do not delay fertility. Don't go and get your degree first and I don't know, do what, buy which house first. Get your baby first, because the longer you wait, the more it is going to be difficult to get pregnant. You need to be able to achieve fertility. Now, like I said, the endometrial cells tend to shrink once the ovary stops giving estrogens. It tends to shrink the endometrium as soon as the ovary stops giving eggs, the uterus knows it's not going to have a baby to carry. So the endometrium also really shrinks. And in menopause, the endometrium should be very thin indeed. The other time we talked about endometrial cancer, then the endometrium grows bigger because of cancer or because of hormones. But this one, when it is normal and it's just endometriosis, once the menopause reaches, then usually it will ease. So uh, the question is, when it you do what is it called, hormone replacement therapy, then you tend to make your estrogen go up, and you tend to maintain your hormones, and you tend to make the endometrium go up, and that can give you endometriosis. Now, there's something called adenomyosis. Adenomyosis means that it's a sister to endometriosis. Adenomyosis means that the cells, the endometrial cells, have actually left the inside of the cavity, but are sitting in the wall of the uterus, and that is adenomyosis. If that happens, then it's not as severe as endometriosis, but it is really also quite painful, because again you are bleeding into the mass of the uterus, and the blood is going nowhere. So the best way to catch endometriosis early is not when the pain has started to appear, or when you are looking for a baby and a baby is not happening. The best time is that, really, for the Princess Dianas that I talked to here, you can all afford a pelvic ultrasound once a year. And the pelvic ultrasound is not harmful at all. So a pelvic ultrasound would alert you to things changing. It would alert you to things like adenomyosis starting. I mean, adenomyosis itself, which could become endometriosis. It could alert you to things like pelvic infections. It could alert you to things like fibroids. So if during your checkup, when you're having your annual checkup for pap smear, kindly also do a pelvic ultrasound. And if there's endometriosis noted, then it can be managed. It's a hormonal management to try to reduce the cells of the type of endometrial cells, or surgical if they are so big that they need to be plugged surgically. So that's, I think, would be my takeaway, that catch this thing before it becomes very rampant in your system. And also, if you want to carry babies and you have been told that you have endometriosis, if you can, try to have the babies early enough. Uh, I have said pain, but it is usually controllable. Don't get depression from the number of pains I have said. It's usually, the pain can usually be controlled, and even the endometriosis can usually be controlled. And even if fertility is not happening in a normal way, these days, for us, for no, I'm beyond that age now. But for you, Princess Diana's, there is the possibility of doing in vitro fertilization. So do not get depression that you have endometriosis or adenomyosis. There are ways around it. So there is always hope somewhere. But yes, it is a very painful condition indeed, which we are not really able to cure completely. It's only time that cures it, or yeah. Now, what some of the things that can be confused with the endometriosis are things that we have already talked about here: pelvic inflammatory disease, ovarian cysts, which we talked about last week, and also what is called irritable bowel syndrome. So I've talked a lot. I said it's not a big topic. It's all about pain. But like I said, it can be controlled. So do not give up hope, even if you have endometriosis. It is possible to be managed. Now I'll drink water as I call my tech guy to come and check whether we have questions. Tech guy, Tech guy. Questions. Tech guy is coming.
This one is asking what's endometriosis, please. I think you've exhausted that.
Endometriosis means that the cells inside the uterus where the baby lives, they are what is called endometrial cells. And those are the cells that break and make a period. So endometriosis means that those cells, those endometrial type of cells, which should only be found inside the uterus, are found outside the uterus. For example, they are found on the bladder, they are found on the ovary. That's endometriosis.
The lady says, she says, thanks for this topic. I'm learning. Dirango, Jamo, a very educative topic, Daktari, and Kirega, following and learning. Felistas, Aeroba, very educative discussion. I think there's a question from the other talk. They were asking. Yeah, I saw a question. What is molar pregnancy?
Oh. Are we to talk about molar pregnancy? Tell them what it is. There was such a question.
Yes, from the previous talk.
From the previous talk. Okay, molar pregnancy means that one is carrying a pregnancy that is not a person. It is a pregnancy, but it doesn't make a baby. It comes from funny fertilization of a sperm fertilizing a sperm. So it makes not a real person who can develop their organs normally. Normally there is the female egg and the male egg. The male egg and the female egg, and they join together and make a baby, and the baby develops into a human being. Now this one, because it's an abnormal fertilization, then it becomes not a person, but it is full of many water balloons. It's a very, very aggressive pregnancy. It holds on to the mother very, very badly. It is a very tight thing. When we see a molar pregnancy, we feel a bit uncomfortable. But what it does is that it can give hormones that are very, very interesting indeed. And finally, the other thing it can do is it can lead into cancer called carcinoma. So when a molar pregnancy is a funny pregnancy that is not a living human being, but a very, very aggressive pregnancy that even digs into the mother's wall, so that we usually will remove it not once, maybe twice or three times, because we remove it and remove it and remove it. Yeah, that's a molar pregnancy.
My voice today. It says here, thank you, Doctor.
Now we finish. I hope you people learned. Yeah. But like I said, it's possible to manage. Yeah. But yeah, it's a very frustrating disease, both for the person with the problem and for the doctor who is looking after them. It can be quite frustrating. Yeah. So, good night.
Yeah, good night.
Good
Just
night. Good
one
night.
more comment here from Naomi Jerry.
Yeah.
She says, thanks, Doc.
We are all welcome. I really do hope we learn and that we are able to mitigate things before they become too late. And I keep telling people, please disturb your doctor. Go and be told that there is nothing. In fact, go and be told you are a nuisance, than wait until things are a bit late. So go. This platform, this She Chooses to Live, is to really tell you, go and seek medical help. Do not take things for granted that it'll go by itself.
Sorry, there's an Ashley Pearson here who's saying, I'm sorry, doctor, but my question is out of the topic. I don't see what the question is. I suppose if she could ask, we can quickly answer.
You can send it on Facebook or something.
Yeah.
Or she's not the one who asked about the molar. And we have talked about the molar.
Yeah.
But there are no, as long as there are health topics, and especially reproductive health topics, there are no questions out of topic. And if we can't answer them, we shall tell you. We will look for the answer and tell you the next time. So don't worry. You can ask all kinds of questions, and you can even post and say what you want us to talk about. So don't feel intimidated. That is not the topic we are covering. As long as it's health, and especially reproductive health. Go ahead. So bye. We'll wait for your question, maybe on Facebook, maybe next time, because we cannot see it. So
okay, there's another comment here.
Mm.
I'm excited to share this testimony. This looks a bit long. Olayinka Adekunle. Clearly, she must be Nigerian. I am excited to share this testimony. I was 3 years ago diagnosed with herpes virus. My medical condition was heartbroken because it was causing so many hour breaks. Okay, sorry, I'm reading exactly how it's written here.
Yes.
I was subjected to different medications by my medical doctor just to control the outbreaks. Despite my visit to several doctors, my health wasn't getting better. All they said they could do for me is to stay on the treatment. At the verge of giving up, I went to the internet to search for a treatment on my own at least, but I found a cure instead. On the internet, I read a testimony of a lady who had herpes. She shared an email address of Dr. Echichioya. Everything seemed to be okay after I took the herbal medicine. I wish I could say that's the end of it because I haven't had any symptoms since. Do not expose yourself to more danger. Use a herbal remedy that's safe and effective. And then she gives contact details here. So I don't know. I think she's trying to speak on behalf of this particular doctor. This is not Kenya. This is class 234.
Yeah, I'm not versed on herbal medicine, so I cannot comment. Yeah.
Okay. So Ashley Pearson has come back. She says here, I was diagnosed with PCOS. I've been under medication for almost a year, but nothing yet. I was advised to go for IVF or ovarian drilling. I need advice, please.
And we have talked PCOS on this forum. Polycystic ovary, PCOS means polycystic ovarian syndrome, and that's a state of the ovary that, to put it mildly, is a bit weaker than the normal ovary, and it is usually unable to make a mature egg for two reasons. One, it makes too many eggs at the same time, so they don't get to maturity and become mature eggs that can be fertilized. And the other thing it has is that it has the polycystic ovaries have a very thick covering, thick ovarian skin. So that's why sometimes drilling drilling the ovary, which means actually drilling like with a drill and making holes into the walls of the ovary. Sometimes if there is an egg, it can be able to release through. So the drilling is to do with the hardness of the wall of the ovary. And the other medication is to try to trigger the ovary to bring out only one egg or two instead of very many. And yes, it can be quite a frustrating exercise, but again, it's not impossible to happen. So yeah. So that's what polycystic ovaries is. So I don't know what advice she needs. Yeah, because uh, IVF would mean that your ovaries would be stimulated to bring out eggs, which is the same thing that what the fertility drugs do, and the drilling. Yeah. So let your doctor actually advise you. But yes, both are doable. The drilling and the stimulation of the ovary to bring out eggs. I think we had, if you look back into our talks, I think we have talked polycystic ovarian syndrome. Yeah, that one we have talked. Although I do not like, but I'm saying I do not offer treatment. So I haven't offered you treatment, but I've told you those are two viable options. You'd have to discuss it with your doctor as to which is more viable for you as a person.
I think that's all.
Good.
Yeah. I don't think there's anything else. Thank you for your questions.
Thank you very much, and pass the knowledge around. Pass it over, pass it around. And I one other request, you Princess Dianas, you have to come up with a solution as to how we shall get to the Wajikos, because Wajikos undergo exactly what you Princess Dianas undergo, maybe even worse, because them a pain is a pain, and there is always a pain. So they are they need this knowledge as much as the Princess Diana's, maybe even more, because you can even Google and sometimes them they can't. So show me ways of getting there, getting to them. With this, she chooses to live initiative.
Yeah, so Ashley has said thank you.
Oh,
But
she's welcome. She's welcome. I hope things work out for Ashley. They usually do. Don't be. And she said it was a year.
yeah, it's been almost a year.
Oh, a year is short actually. Don't give up. A year is very short. There is even some way we graduate the medicine, a few months this, a few months that, a few months that. So don't give up. A year is still a short time.
Today, it looks like you're having quite a number today. There's this just for injury minor. She says, please check mine up. Let me see. I can't see any. Just for injury, I think I can't see your question, so maybe you can repost it if you don't mind. Sometimes you can post questions and we miss them. They don't appear here. So please repost your question because it's not here.
So we'll post it for next time. We make sure we'll answer it next time.
Okay.
Yeah. So bye bye.
Oops.
Yeah.
We've been cut off.
Bye.
I think by Facebook, it's just saying sorry, we're having. Okay.
We're having trouble playing this video.
Yeah, I think we've stayed for too long. Anyways,
Oh.